Welcome everyone. Good morning. It's so wonderful to have you join us for this really important conversation. But before we begin, again, I just want to remind folks, you have the option to listen in English, Spanish, or follow along in ASL. Just click the world button at the bottom of your screen. It says interpretation. And we're recording this and also recording this on Facebook Live. We are so excited to bring you our symposium called Building a Robust and Proactive Public Health System in Connecticut. This event is hosted by the Expand Services to Save Lives Coalition, which brings together community organizations, unions, and activists. Today, we will hear from frontline public sector healthcare workers, community organizations, advocates, and policymakers who will talk about a crisis in Connecticut, a crisis that's hiding in plain sight. Our symposium will highlight how this crisis is the result of decisions that have been made to underfund and devalue our public sector healthcare safety net, serving our most vulnerable citizens, including at-risk children with mental health issues, people with developmental disabilities, people with severe mental health or substance abuse conditions, people incarcerated or leaving incarceration. Our symposium will highlight the reality on the ground, that there's a public sector staffing crisis where 1 out of every 3 healthcare positions in state agencies is unfilled. Our residents cannot get the life-saving care that they deserve. And our symposium will highlight how the state of Connecticut has the moral obligation this year, in 2023, to expand services to save lives as an urgent matter of racial, gender, and economic justice. The state has had multiple years now with budget surpluses. We now have multiple billions of dollars in surplus. The rainy day fund is overflowing, and we live in one of the wealthiest states in the country. We saw it multiple times in the chat. The problem is not whether the state has the money, and that's why our elected officials need to make expanding services a priority this year. There is absolutely no excuse at this point not to fund and not to build the system that is truly needed. And our publicly run healthcare services in DMHAS, DDS, DCF, and other state agencies are designed so that no one should be turned away from services, regardless of race, gender, zip code, immigration status, income, or insurance. And this is because state healthcare services often serve our most at-risk, complex, and highest need residents, folks often without insurance, folks often turned away from care in the private sector due to their high acuity or complex needs. Service recipients are disproportionately Black and brown, disproportionately from our cities. And we've created these public services together because we believe that every resident's life should be valued. Every resident's life should be saved. But the reality is that today, after decades of service cuts, after decades of underfunding the private sector and shrinking the public sector, and during the worst public health crisis in a century, we as a state are failing to save people's lives. We have children waiting in hospital emergency rooms for weeks on end, waiting in hospitals during a time of acute crisis because DCF hasn't been able to hire enough nurses to reopen units at Solnit South, even when we have the resources to do whatever it takes to recruit healthcare workers. We have people struggling with addiction and multiple mental health or medical conditions, people who need the highest level of care, what's called medically managed care, cannot receive it right now because DMHAS is running addiction services at 50% capacity due to the staffing crisis in the middle of an opioid epidemic. We have women who would be served at the nationally renowned women's rehab program, the STAR program in DMHAS, who've been turned away because the program has been closed due to the staffing crisis. We have families caring full-time for loved ones with developmental disabilities who can't get a break off more often than once a year because DDS has yet to expand its respite program. We have people leaving incarceration who are 12 times more likely to die in the 2 weeks following their release because coordinated statewide reentry healthcare services just do not exist. But these cuts have not affected all of us equally. When DMHAS closed a third of the young adult services residential beds in Hartford last year, it was Black and brown and poor kids in Hartford who were the ones without services. And when the state shut down Fairfield Hills, closed Norwich, closed Cedar Crest mental health facilities, and the state brought forward the war on drugs and mass incarceration, it was huge portions of Black and Latino and working class white communities and people with untreated mental health conditions. These are the people that are locked up. Our state prison in Newtown should not be the largest mental health facility in the state. That is why we are bringing these stories out of the shadows. For way too long, some politicians have slashed our public services, privatized our public services, and underfunded our public services. They've tried to provide services on the cheap through contracting out and paying poverty wages to nonprofit providers, a predominantly Black and brown workforce. And this relentless attack has produced a staffing crisis so severe across state agencies that 1 out of every 3 healthcare positions is now empty. Life-saving services have either suffered cuts or no longer exist. Our coalition has a vision to not only restore services after years of cuts, but expand services to save lives so all our people have access to the quality healthcare they deserve as human beings. And we are saying the state needs to listen to the people who rely on services and the people who provide services. These are the people who can tell us how to construct a public healthcare system that truly provides all people with the services they need to survive and live a good life. So today, our coalition is launching our legislative agenda, which we believe will take meaningful steps towards guaranteeing that every single resident who is at risk has access to a lifeline to survival, and a lifeline to a better, healthier, thriving future. And we can make that guarantee as a state by passing legislation to address the state healthcare worker staffing crisis through recruitment, retention, and creating educational pipelines for nurses, by allocating $80 million to fund an expansion of addiction services, peer-run respite, mobile crisis, bilingual services in DMHAS, to fund an expansion of children's mental health services in DCF, to fund an expansion of respite and wraparound services in DDS, to fund the establishment of a statewide reentry healthcare program in DPH, to fund the expansion and regulation of DOC medical services and mental health services, and to fund the expansion of DOC educational programs and job pipelines. We have multiple billions of dollars in state coffers, and we're one of the wealthiest states in the country. We have the resources to fund these programs. And the vast majority of us believe that everyone, not just the lucky few or the wealthy few, should have access to the services that they need to save their lives. Now we need our elected officials to step up and expand services to save lives. Only then we can finally make good on that promise that we've made to each other and truly advance racial, economic, and gender justice for all. So our event will begin with a panel describing the crisis of safety net services across Connecticut, and we have fantastic panelists. At the end of the panel, our audience will have the opportunity to ask our panelists some questions. If you have a question, please send them in the chat directly to myself or Norma Martinez-Hosang. Then we'll take an hour-long break. After the break at 2 p.m., we are so honored to be joined by Senator Saud Anwar, Chair of the Public Health Committee, as well as Dr. Emily Wang from the Transitions Clinic Network and the SEICHE Center for Health and Justice at Yale, and a recent recipient of a MacArthur Genius Grant. After hearing from Senator Anwar and Dr. Wang, we'll hear our second and last panel of the day, which will be a conversation about the tremendous opportunities we face in this moment to build a public sector safety net of the highest quality possible for all residents across Connecticut. But before we get started, I would like to pass the mic to my fellow 1199 member and brother, Brian Williams. He's a certified addictions counselor in the Department of Mental Health and Addiction Services. He's worked tirelessly to help suffering residents across our state as both a clinician and as an organizer. There's just no one better to help introduce today's event. So Brian, I'll pass the mic to you.
All right, so thank you, Becky, and good morning, everybody. I'm excited to be here today, and we'll ask that as we start our event this morning together, that you keep these 2 truisms in mind during the symposium. The first one is public policy is a set of laws, guidelines, and actions decided and taken by government in favor of the public, the emphasis being the public. The second truism that I'll ask you to keep in mind is budgets are moral statements of priorities. And this is true whether it is on an individual basis, a family's circumstance, or on the state level. A family that makes the choice to put away 10 or 15% of its income towards their children's education is a family that's making a moral choice. about what it values. I want you to know that the choices we make, as a state, have direct impact. A few decades ago, we made a commitment as a state, as a country, that what was happening to our fellow residents who were consuming tobacco was untenable. So from multiple directions, we addressed this in the courts, in our laws, in public education, in cessation programs. I know we have new challenges coming with some of the new products that they're bringing on, but the reality is the consumption, the use of tobacco and its impacts have reduced over this period. So the choices we make and the commitments we make have consequences. So in order for the government to make good public policy, it must be properly informed. And this includes hearing from its citizens and residents. So with our gathering today, we will begin to inform and mobilize our fellow citizens so that we can ensure that the state of Connecticut meets its moral obligation to care for its most disadvantaged citizens by establishing public policy and ultimately a budget that provides additional resources to address our growing challenges, which Becky laid out so clearly. What are some of the things that we're asking for? We're asking that the state takes seriously the fact that we had an opioid epidemic that predated, this pandemic, that we've all struggled through this past 3 years, to the point where, the state's own Departments of Public Health's data is telling us that you're more likely to die from an overdose today than you are from a car accident. This is evidence of a clear need that needs to be addressed. And we say that it is an immoral act if one of our residents picks up the phone and attempts to call one of our state-run facilities to seek care, and there is nobody on the other line because of staffing or whatever the reasons may be. If somebody calls and they're told, no, we do not have any beds because some of the beds have been shut down, it is immoral. We believe that it is not a commitment to moral living, to public policy that's rooted, in a proper moral basis, for a child to show up in an emergency room seeking care, only to be kept there for days on end without receiving appropriate age or clinical care because there is a program at DCF that has been shut down. It is immoral when that child is kept in that emergency room not receiving the care that they need. It is equally immoral when a client who is receiving care under the umbrella of the Department of Developmental Services needs respite care to be stabilized because maybe they've become dysregulated, or that client's family who are struggling mightily to provide care for them need a break to maybe just go away for the weekend for a day or two so that they can replenish and come back. It is an immoral act when we are not providing the appropriate respite services for these families and for these clients to receive the care that they need. It is equally an immoral act when one of our fellow citizens behaves inappropriately, gets held accountable by being sent to the Department of Corrections. It is an immoral act when we do not provide the appropriate resources for them to be appropriately rehabilitated and the appropriate reentry services that increases their chances of success and reduces the chances of recidivism. It is an immoral act when we do not provide those resources, and they have consequences. We will argue that it is immoral when the state does not commit to provide these, basic, services. We live in the real world. As any of these policymakers, we realize that sometimes choices have to be made against, competing demands. But like Becky mentioned very clearly, we are currently in a position where we have a surplus. So my question would be, if not now, when? We are in a position to strengthen and make our social infrastructure, our public, health, infrastructure a whole lot more robust, and we must. The other thing that's interesting is each of these demands that we're making is actually economically sensible. If we take care of the addict who is struggling today by providing them care today, we are saving ourselves from the cost of taking care of more profoundly challenging health problems that they will get down the road. So the person who's cared for today and enters into recovery is a person who's not going to be needing hepatitis, treatment, is the person who's not going to be needing, kidney transplants or any of these other more severe consequences. If we provide the re-entry dollars, for the folks coming out of being incarcerated, it is cheaper to do that and keep those fellow citizens of ours in the community than it is to incarcerate them at tens or thousands of dollars a year. Our demands are not only morally necessary, they're economically sensible, and we ask that our policymakers make it a priority that this time they make the investments that will bring us through this very challenging times that we are going through. While we ask you, and do so politely, we also say we will continue to inform our fellow citizens and that we will mobilize and organize ourselves in whatever way is necessary to ensure that this is done. It is a moral imperative, and we will fail if we're not advocating, so we will not stop advocating. And I ask you all to just stay engaged with this, symposium today, and to also join us as we move forward beyond here to ensure that these demands that we're making become the realities for the folks who need it so much. Thank you very much.
Thank you so much, Brian, for those powerful remarks. Before we begin, there are so many people who made this event possible, including really important research from A Better Connecticut Institute and the student researchers at the Yale Law School Clinic, the CRP Law Clinic. We are so grateful. Now we're going to move to our first panel of the day. I am so pleased to introduce the moderator for this panel. I'm sure many of you have read her byline. Christine Stuart is the editor of CT News Junkie. She's regularly writing all sorts of issues affecting Connecticut residents, and she's provided consistent coverage of the crisis of unmet need in our communities. Christine, it's an honor to have you join us as moderator for our first panel. I'll pass the mic to you to frame it and introduce our panelists. And just one reminder for our moderator and panelists to speak slowly to make sure our interpreters can keep up. Christine?
Thank you so much, Rebecca. And so before we define the crisis, we're going to have our panelists introduce themselves and how they work in this space. So first we have LaToya Pemberton, we have Thomas Burr, we have Maricel Garcia, we have Kathy Flaherty, and Keisha Johnson. And we're going to start with LaToya.
Hi, I'm LaToya. And so I am a recovery support specialist for Connecticut Valley Hospital. Am I just introducing myself, or am I talking about a little bit about how I got here?
Introduce yourself and you know how you work in this space, exactly, what you do and what services you provide.
Okay, I'm a recovery support specialist for Department of Mental Health and Addiction Services at CVH. I am a support to all of the people who are recovering in the hospital. I'm there for them when they need to talk. I run groups and am a one-to-one support as well.
Thank you. And next we have Thomas Burr.
Yes, good morning, Christine. Thomas Burr, I'm the Public Policy and Affiliate Relations Manager for the Connecticut chapter of the National Alliance on Mental Illness, NAMI Connecticut. And in my role here in the organization, not only do I work in the public policy realm to try to advance our legislative priorities, but also work with our network of 9 local affiliates that are scattered throughout the state of Connecticut and helping them more effectively deliver our wonderful support groups and education classes and other programming that we provide to the communities here in Connecticut.
Great. And next we have Marisol Garcia.
Hi, everyone. My name is Marisol Garcia. I am a coalition member of the Regulate Connecticut DOC Healthcare, a former YWCA policy intern. I am here representing the interest of the formerly incarcerated and those that are incarcerated. I am a policy major from Trinity, actually, and have graduated with my policy degree. I'm here primarily to promote the interest of those that are still behind the walls and those who have come home and who have struggled with healthcare issues that have stemmed from the lack of staffing and services being provided upon release and prior to release that affects both sides on the fence. Healthcare workers, their families, as well as incarcerated people and their families.
And next we have Kathy Flaherty. Kathy.
Thank you. I needed the host to let me unmute myself. My name is Kathy Flaherty. I am the Executive Director of Connecticut Legal Rights Project, and we provide legal services to people who are eligible for mental health services from DMHAS, the State Department of Mental Health and Addiction Services. So we represent people who are currently inpatients in the state's state-operated inpatient psychiatric facilities. We also represent people in the community when the legal issue that they are facing is a civil legal issue where their mental health condition impacts it. So maybe people who are getting evicted because of disability related behavior or facing discrimination due to disability, having problems with probate court. So I'm very pleased to be here. I'm also a person who's living in recovery from my own diagnosis, so a past service user of the private mental health system.
Thank you. And our last panelist is Keisha Johnson. Keisha?
I am Keisha Johnson. I am a registered correctional nurse for the Department of Corrections, and my job is to provide and deliver quality of care to our incarcerated population, and I'm very pleased to be here.
Let's hear from our panelists. Let's start with LaToya. I guess this is the easiest way because the host is unmuting here. Define the crisis from your vantage point. Define the crisis from where you're sitting. What is the crisis and how is it impacting the population that you serve?
Well, first and foremost, June 27, 2012, I actually went through a detox. And from that detox, I went to a treatment facility afterwards. And it was at that time where I realized that I actually wanted to get help, and I started to regain my sanity and regain some self-respect and dignity. And it was because I didn't have to concern myself with not being treated. That helped me out a lot. You know, I am now 10 years clean in recovery. And because I'm deeply rooted in my recovery, I am a huge part of the recovering community. So I serve a lot of women. And this is why it's so important that the STAR program be funded, because I get 3 to 5 phone calls a day based on people begging for beds and asking me to help them in the middle of the night to find some place for them to go to. And I am rooted in the community. So it's Hartford, New London, Norwich, Groton. All of these women are from all over because I travel all over to be a sponsor to these women, as my sponsor did for me when I got clean. I see a lot of women, and over the past, even just the pandemic, I saw pregnant women in recovery displaced on a Friday, and on a Monday, they had nowhere to go from a program that was not funded anymore. And Groton, I also saw 21 beds in New London at one time for women go down to 10. They took 11 of those beds and they gave them to the men, you know? And so this is one of those things where I understand completely that there are times where men and women have to come together, but if we could fund and have the STAR program reopen, they would be able to feel safe. They would be able to, I recently saw a woman sit across from her sexual offender in a group. and it devastated her. And I had to console her afterwards because he deserves the right to have recovery and treatment as well. So I had to serve this woman and also serve the man because they both have a right to recover. So I'm watching this from two different standpoints. And if this is something that we can fund to prevent these things from happening, it makes for us, it creates where a person can be here 10 years like myself and go into the fields of recovery support and help other women and other men to realize that it does get better. But without the proper care and without care, period, they're going to be turned away. You know, there's just not enough beds. And these are people's kids and daughters and sons and aunts and uncles and nieces and nephews and friends that are dying in the street because they have nowhere else to go. And when they call me, I really don't have the answers, you know? So I'm really grateful to be able to be here and talk to people who I know can help. The ears that are on here can actually hear and hopefully come up with a solution to save our lives, because those are lives out there. They're not just addicts or recovering people who are not going to get it. They need the support of the system to be able to give them what they need so they don't have to worry about money. You know, everybody doesn't have that. It's a tough time in life right now.
Thank you. And so, Thomas Burr, can you define the crisis from where you sit? What is happening right now?
Yes, and but first off, I just want to thank the fine folks at SEIU 1199 for organizing this event. Appreciate that. And I should just mention before I get into my answer that as an organization, NAMI focuses on three overarching public policy areas. Number one is improving care. NAMI fights for policies to ensure people get the best possible care. This includes expanding access to health insurance, requiring parity coverage of mental health care, and ensuring that the right services are available at the right time. Number two, intervene early. NAMI fights for policies to ensure people get help early. This includes better research to detect and identify mental illnesses, integration of mental health care into primary health care settings, and access to mental health care in school. And number three, divert from justice involvement. NAMI fights for policies to get people help, not handcuffs. This includes expanding access to crisis services, promoting best practices in de-escalation and diversion of people experiencing psychiatric crises to treatment. Now, to answer your question, Christine, in a word, what we're seeing is gridlock in Connecticut's mental health care system. As an active family support group facilitator in my organization, I hear again and again how people face just ridiculously long stays in the emergency rooms, waiting for a hospital bed, to the point where sometimes people just leave because they just can't wait any longer. You know, and when they do end up staying in the ER, it's traumatizing for people who are already in psychiatric distress. It's not a therapeutic environment. And once people do manage to get a bed, they're often discharged before they are really ready to reintegrate back into the community. And when they do get discharged, many face long waits to get an appointment with any type of mental health professional, which often then drives people back to the ER. And they just rinse and repeat. And of course, people who can't get the help that they need too often just cycle again and again. And, you know, cycling through the ER or an inpatient hospitalization, or even worse, our jails and our prisons, which are not therapeutic environments. And it shouldn't be a crime to be sick. Not to mention, these are very expensive interventions, as Brian had mentioned, as far as being a moral obligation to both the people and the taxpayers. This is also an issue for the few who are lucky enough to find a temporary placement in a DMHAS respite bed. This system is also woefully understaffed and gridlocked. The entire situation is a disservice, not just to the people being served, but also to mental health care workers, as well as the taxpayers here in the state of Connecticut. Thank you.
Thank you. So next we're going to hear from Marisol Garcia on defining the crisis from your vantage point there.
So I've heard my fellow panelist, Mr. Bird, describe it as the rinse and repeat cycle. That's exactly describing the healthcare circumstances in mass incarceration, as well as the morality and responsibility. When people go to prison, they give up their freedom. That doesn't mean they give up their right to health. Unfortunately, that's what a lot of people find themselves doing. I am coming at this from the vantage point of, I used to be a hospice worker while I was incarcerated. And I've watched many people, toward the end of life or just palliative care suffer due to the fact of the staffing shortages prior to COVID-19, but even more highlighted because of COVID-19, where there is not enough nursing staff and they're very dependent on their hospice workers. But with COVID-19, hospice workers weren't allowed out of their units to go take care of people, which put a further strain on staffing. My friend passed away last August in the final throes of discomfort because, again, not enough staff, no hospice worker to be able to make her final time as comfortable as possible prior to her time. We talk about incarceration takes 2 years off your life. Imagine what it is, Ms. Pemberton spoke about sobriety and recovery. 2 years off your life as soon as you release back into the community, because again, you have no services to come home to, or you don't understand the process. These are all the issues that those who are recently released are facing, because again, we have not enough money, not enough services, not enough employees all across the board. It is affecting the mass incarcerated population, their family members and the staff, both all across the board. The quality of life, I could go on and on. I made it a point when I was released I am a public policy analyst by profession and every other aspect. Healthcare has become my specific priority because I watched my friend die, unfortunately, because there's only so much you can do with the hands that you're given. This issue has reached a crisis point here in Connecticut. I find it hard to believe that the Connecticut government would rather have its coffers full and bursting at the seams than providing residents, their employees, and their incarcerated population with services that they need in order to survive and live in the community, in order for it to thrive. I can't see year after year us keeping money, but not providing services. But obviously with STAR closing, all the other services that we need, obviously this has just become, it's beyond healthcare services, or the lack thereof, has now become what the opioid epidemic, another layer. Now it's just become a much more proportionate issue that's affecting those that are not only who provide the healthcare, those who are receiving it, those who are incarcerated and those who are released, and their families, both sides of the fence.
Thank you. And next we have Kathy Flaherty, who's also going to define the crisis. And, I know that you've been at this for many, many years, and will be able to nail this.
Okay, thank you, Christine, for your confidence in me. I appreciate that so much. And one of the things that I need to say, obviously echoing Thomas's thanks to everyone for inviting CLRP to be part of this symposium this morning, is I want people to remember that Connecticut Legal Rights Project represents that portion of people who are not getting what they need from the existing services. So sometimes that's helping people where the system is trying to, for lack of a better word, force itself on them, whether that's involuntary medication or involuntary electroshock. And the person does not want that and does not want to consent to that. And I would ask everyone to remember that when something is called care, but it's provided by coercion and without consent, it's not compassion and it's not care. What we need is that system where you have that wide array of potential services, of a menu available to you, and you get to pick your pathway towards recovery. I certainly hope, and I've heard it for decades, and I really think we ought to reconsider talking about things this way. There are lots of people who refer to correctional facilities as our largest mental health care provider. They're not mental health care providers. Let's just stop referring them to them. They are the cage, they are the box that somebody living with a mental health condition is currently residing in, and they are entitled to good quality care while they are there, but they are not mental health treatment facilities. So I think we might want to consider collectively deciding to advocate a little differently. Some of the things I took notes as I was listening to my colleagues talk, because I have an idea about what I'm going to say, and then people say things that kind of lead me to conclude something else. But referring to women with that past history of trauma, another place where we see a lot of shortage available for women is forensic mental health. The services that are available to women are simply just not the same as they are for the men at Whiting. And women have a very different experience in that maximum security facility than the men do, especially if they're here long term. People have the legal right to receive treatment in the least restrictive environment, which means they should be receiving services in the community. I'm somebody whose journey in the mental health system took place starting in the late 80s and early 90s. And I watched the system change while I was in it as a patient to become a very crisis-oriented system. And you might reach out for help, but it just wasn't there until, like you said, Tom, somebody goes to the emergency room. I want to talk to those people who are allowed to leave the emergency room when they get sick of waiting, because if you go to an emergency room on a psych reason, they don't have to let you go. You can tell them you want to leave. But that's one thing that I think a lot of people don't necessarily understand about psychiatric care too, is once you put yourself into it, there are times you might want to walk out the door, and it really becomes the clinicians may or may not use their key to let you out. And that's when people sometimes call us and try to go the legal route. Thanks.
Interesting. Thank you, Kathy. Next, we have Keisha Johnson. Define the crisis from your vantage point there at the DOC. And we're going to get to all the staffing issues after this.
Hi, everybody. Again, I'm Keisha Johnson from the Department of Corrections, one of the registered nurses there. And as you know, as a medical staff, that our duty is to cause no harm and to provide high quality service to our inmate population, that we do not judge, we just deliver the care that they need. However, our staffing crisis is so short that our staff is very burned out, so burnt out that our staff is very frustrated and exhausted. Some of the examples would be our nursing sick call list is what the inmates are required to do before seeing a provider. And when staffing is short, we have to shut down that post because we have to get medications out, diabetic lines. Our lines are not like the normal lines. We have, 200 plus inmates in front of us coming down. So it takes a bit of time to deliver that care. So therefore things get missed and the sick call list gets behind. We have a high rate of ER emergency room trips because our doctors can't keep up with the ratio of our inmates care, because they're trying to treat acute care and not preventative care due to so many inmates and not enough staff. So therefore, once we get to see the inmate, there's almost a problem. And, we feel bad about that, because when we see that, we like, we're not supposed to be, I get emotional, I'm so sorry. We're supposed to do no harm. So when we see inmates, our patients with diseases coming up with cancer that we could have caught, but there was no way of knowing, because like a needle in a haystack, because we're seeing these people every day, it gets frustrating. It gets very frustrating. We try to support ourselves to build them around, but it's very hard. Another situation is like with our chronic care, to see these patients, our diabetics, they should be seen every 6 months. Sometimes they don't get seen because they're still trying to keep up. Our patients with CPAP machine, there's no way of us knowing, because contracts was cut, of if they're using it or if they're not using it, preventative medicine that we're supposed to do. There's definitely a crisis. It's a bad crisis. It's a bad crisis. Nurses are being, mandated and drafted every day. We are there, we are on the front lines, we haven't gone nowhere. We just need the added support and resources and the tools to do our job and to do our job effectively.
So
Thank
how
you.
has that, Keisha, I'm going to
Right.
stick with you for a second. So how has that changed over just the past 2 years? How much mandated staffing are you having, are you seeing, and how much further behind you feel like you're falling?
We're falling way behind, especially in the last 2 or 3 years. We have never had so many emergency room trips, although they're saying that we have less inmates. We have more acute inmates though, because of the lack of need to see the provider. We have more sick inmates coming in, mental health inmates coming in who wasn't getting treatment on the streets. I think someone else had just mentioned that. They don't belong in jail, they belong on the streets, but that's all in the ER too as well. And then they end up in our job, in our population. So therefore, the mandates are like almost every day. Like I can show you an empty schedule. Sometimes we have no nurses on nights. We have to pull to do things. Just recently, a nurse was mandated for 20 hours, which was, you know, at some point you can't even take care of the inmate. You have to take care of yourself. So it's an ongoing process.
So have there been any attempts at hiring? I mean, the administration has said, hey, we're going to do this, we're going to focus on this, but it's not been, your ranks have not increased.
Yeah, so at us 1199, we pushed, right? So we got these nurses to apply, but it was the pay, the overall pay. People have to pay their bills at home. They willing to come, but the pay is so low in the state. We can't get nurses, we can't keep providers, only the ones that's been there because we have some time there. But the people coming off the street, living in Connecticut, you know how it is to pay milk and gas is up. They can't live off that pay, regardless of what the benefits are. They still have to pay their bills. So that's one of the major issues why we can't get the nurses in there and in corrections to stay. And then the ones that do try to come and stay, they're now being mandated like crazy. They know it's a mandated post, right? They know it's a mandated job, but to get mandated every day, they rather go out somewhere else. So we can't keep them.
Marisol, do you want to weigh on this issue of staffing there from your vantage point and how it impacts this?
Most definitely. Prior to my incarceration, I actually worked in healthcare, so I know very well what Ms. Johnson is talking about. We talk about mandatory overtime, 16 hours max. Something of 20 hours is unheard of. After a while, mentally, as someone who's been incarcerated and as someone who's been a hospice worker, I've watched the burnout happen in the nursing staff. When I've done vigils for people who were, on their last throes of, leaving, they can barely take care of themselves, let alone these people who are, passing out of life or even doing palliative care. Basic things of medications, they go south because of the fact that people are so tired or they're so stretched so thin. That's an undue burden to put on people that then has ramifications that would pass out to not only those who are in the medical unit, at the correctional facilities, but to their families, because somewhere down the road, someone ends up getting ill. I said earlier, the incarceration takes 2 years off your life. Someone spoke about the cancerous scares. You see that very much. The rates are what they are. The State Center for Health and Justice has done studies. Dr. Wang, who's actually also on this symposium, will tell you the very same thing. You see the carceral rates in cancer in an incarcerated population. It's unimaginable. So only imagine things are not getting caught. Staff is being burnt out. People are paying the price due to these staffing shortages and these, again, is it more important to have our coffers full than to watch, look for the healthcare for your employees, the state workers, and the incarcerated population? I really cannot believe that is the priority in our state. If that's the case, then You know, we talk about how society judges us based on how we take care of our residents and citizens. So it should be shame on Connecticut if this is what we're doing to our healthcare employees and our incarcerated population.
So that's more in the public sector. I want Thomas Burr to talk about the provider shortage in the private sector, in our hospitals and our our psychiatric facilities, aside from CVH, in the other, just in general, why don't we have enough providers to be able to handle the current load of clients?
You'd think I'd have the Zoom stuff down by now. So, yes, do we see this in the private world? Absolutely. And, again, it's everything I think that Marisol just touched on. It's just people are burned out. These are not easy jobs. And it's just, COVID took a system here in Connecticut that was, stretched to the breaking point and just broke it. And that's really, I think, what it all comes down to. And the caregivers who are left in the system are getting burned out. And we just need a huge investment in workforce. And some of that was addressed in the last session. And this is going to be something that's going to require, I think, some real creativity. Because there's not enough people. It's not just a Connecticut issue. It's throughout the US. And I think it's going to require incentives both at the front end with the educational systems and encouraging people to go down that career path, as well as incentives for the people who are still struggling to keep up with the demands currently. Try to figure out ways to ease the burden for the hours they have to put in, and certainly make maybe some financial incentives to have them stay as opposed to retire or go find a different job. But I think you do reach a point sometimes where there's not enough money in the world if you're just working so many hours, your life is hell. So I hope that helps.
LaToya, you see it all the time. The lack of, obviously, the lack of beds, the lack of providers. Is there any solution to this from your perspective? Obviously, it's very difficult.
It is very difficult because I agree with a lot of the other panelists. The staff are overworked, and they do agree that those beds should be open in the STAR program even now on the campus, but they can't staff it. They can't staff, And again, just like I said, the women and children program that closed down with their babies with a 2 days notice was because it was understaffed. And, and it's kind of, it's like, where does it end? Because at the end of the day, I mean, it's something that could be fixed. It's not like it can't, there's not a solution. We're not asking for a lot. We're asking to fund something that's a part of all of us. It's a part, we all work towards this. So why can't we choose where the money goes? They need the money.
So we need access to services. I guess I'm going to throw this out to whoever wants to answer. So maybe possibly raise your hand so that we know to unmute you. But where do, there are people who are not getting services right now. And so how do you convey that in a way that makes policymakers pay attention? I mean, what is the most compelling argument that you can make to say, hey guys, you really need to fund my services? Kathy Flaherty is going to take this one.
Thanks for at least giving me first crack at this one, because I think people really need to share the stories of their firsthand lived experience of this system. And I think that's for the people, because it does so many things. I think a lot of people make a lot of assumptions about what it is that we need to do, but it's such a multi-layered problem. I mean, what is happening to staff every day when the system is not set up in a way that they can serve the people that they're there to serve in the best way they can, that's a moral injury to the staff every single day. And the longer that that continues to go on, it just creates sort of this cycle where things really just don't have the opportunity to get better. I think one of the things the state really needs to do is have an overall vision of what it wants its mental health system to look like, and all the different things that, and not just mental health, addiction services, human services, social services, and figure out how to put those different layers of it together. Because what I hear from people who are in leadership at these places have said, we have actually done more hiring in the last 6 weeks than we've done in the last 3 years, but it's still not enough. And if you don't have places for those workers to live, like, this is why everything gets wrapped together. You need affordable housing so the workers who are doing these jobs can afford to live here. And we need to take advantage, and Tom, you may pick up on this more and keep running with it, is there is a whole peer workforce. I mean, LaToya talking about being a recovery support specialist, that, those exist both on the mental health side and the addiction side. And you're creating a workforce because a lot of people have gone through training, but then they're not offered the job opportunities. And as someone who has been in services myself, I cannot tell you the time how important it was to have that support from peers, because there is a role for the professionals, I will admit that, but really recovering and building that great life took learning from my peers who had walked that walk before me.
Tom, do you want to take a stab at this? What you need to do at the state legislature this year to get them to pay attention and to understand the issue, because it's obviously a very, it's something, like Kathy said, that touches everything.
Yes, and Kathy kind of teed me up here, which is great. I absolutely agree about the whole concept of utilizing the recovery support specialists, both in the mental health and addiction sphere. There's been all these people trained, and yet most of them aren't working in this space because they can't earn a living doing it. Some of that is because the certification process got all balled up and still needs to get sorted out. That needs to be, I think, a priority moving forward here. Get people the ability to be paid. I think you also, Kathy, touched upon just the overarching framework here in the state of Connecticut. That's actually one of our 4 public policy priorities this year, is to really press the legislature to create a work group that can focus on how do we get to where we need to be as far as a integrated, no wrong door, fully robust mental health system, both, clinical mental health services as well as peer services that really does meet the needs. Because right now the system we have is not only woefully understaffed and dysfunctional and broken, but it also, even if we had it fully staffed, what exists today, I don't think truly meets the need. Because again, some people do respond well to a clinical environment, but so many people don't. And they're really left kind of hanging right now. One of the things that we're advocating for is a network of 5 regional peer-run respites. It's a model that exists in other states, 15 other states here in the US. In fact, all of our surrounding states that surround Connecticut have peer-run respites, but we don't. And that's a model that really has shown wonderful promise. People will go and then they'll never have to go back. So instead of seeing a lot of folks where the clinical model doesn't necessarily resonate, but they end up recycling themselves through the ER and inpatient hospitalization, which is sometimes traumatizing for people, they have an alternative. Go to a peer-run respite and talk to the peers, talk to people who've been down these roads, know how to navigate the system, know what the kind of things that work, but most importantly, are just people they can connect with. It's not a doctor-patient relationship, which is by definition kind of arm's length, but really talking to a peer, talking to someone who wants to make that connection with you, I think is huge and a big missing piece of the puzzle here in Connecticut.
Marisol, how do you get lawmakers to listen? I mean, yesterday they were basically like, school lunch, we have a lot of money, but we're not gonna, not gonna be spending any money on that right now.
Kathy and Thomas both, the lived experience. Last year, the coalition put forth Senate Bill 448 about doing the continuum of care in corrections. And I think what they need to see is that nurse that worked 20 hours and her exhaustion. I think they need to see and talk to Tiana LeBoy, who ended up giving birth in the toilet, as we all know, the survivors of the malpractice that ends up happening because of the staffing shortages that you see. In the last 2 years alone, we have settled suits, negligent suits for medical mal and corrections to the tune of somewhere in between $12 to $17 million. That right there is the staffing budget for several healthcare, for several facilities, and for several things. We talk about peer support on Kathy and Thomas both. Those who have been incarcerated and those who go through addiction and mental health services, I believe LaToya can speak to this. People want to be of service when they come home. They need that type of thing. And I think they're overlooking those that are coming back into the community while they're incarcerated, can learn these recovery skills, can learn these things, or being provided these services will then further on, it lays layers on top of one another. Without these things, people cannot help themselves. Staff is going to get burnt out, and all you're going to see is these economic numbers just keep rising. Programs are going to fizzle out because people, again, have no idea where to go. They're not provided the direction in which to do so. And then you have people who may have the skills, but they're not comfortable, as Thomas said, in a clinical setting. They may be more in another setting. All these things are interrelated. I think what the legislature needs to understand and look at, these lived stories, they need to talk to people, not living in the ivory tower of legislation. Look to the people, those that have been incarcerated, the staff that it affects, and the families that it affects. It all plays one after the other.
LaToya, how much money do you think that you've saved the state by being able to provide these services and help, the women that you've been able to help?
They owe me a lot of money. And so I just want to say, as a recovering woman, this is the greatest panel in the world. I am not even kidding you. Just listening to all of this is the recovery support specialist is and when he was talking about peer run, this is just amazing. Recovery support specialist on the units is one of the best things I've ever seen funded in history. Honestly, I encounter each recovering person that I meet, and I help them fill out the forms while they're still in the treatment, because at the end of the day, it serves as a purpose for their voice for these type of panels, just as this one, so they continue to fight for the next person who's recovering and doesn't know how to use their voice yet. This is just really, really empowering, even for me, to continue to go forward and to say, it's okay to ask for help. We need help. We're asking people who should want to do it more than anybody else to service our state. This is just something that it should just not be, we talk about it today and then it's over with. It's bigger than that. It is bigger. And then she was talking about leaving jail. When you come out, you're so hungry. You're so hungry. You want to get your life back together. You want to get a job. You want to continue to do things you thought about for all that time you was locked away. And what better way to do it is to have someone waiting for you who understands your journey, that can help you to integrate back into the community. And that's exactly what happened for me. I left the treatment. I went to another treatment. I asked a lot of questions. I did a lot of work on myself because I was given that opportunity in a treatment facility to go, and not have to concern myself with, I just think that we shouldn't want to see people die alone. because there are people dying every day alone, whether it be in their heads or whether it be in the bathroom of a Dunkin' Donuts. There are people dying every day alone that can get help. And we can continue to use our voice to ask for help for these people. And I'm going to continue to do that.
Thank you. And so I want to ask, I want everybody who's on the Zoom call right now to start thinking about questions, and the questions, you can put your questions into the chat, and I'll get to those shortly. I just want to ask how the austerity measures the state has taken, how has that compounded the problem over the years? I mean, I know that obviously the pandemic didn't help. It increased these problems for access to services and the funding of services. But how has it, is there a way that you can articulate it to help make your argument to state lawmakers, which the governor is proposing his budget next month, and we're going to see the first draft of that, and then you get another go around with lawmakers. So Kathy looks like she wants to tackle that one.
It's very, very strange doing this work when there's all this money out there, I have to say, because I came into my position at CLRP during that time of permanent fiscal crisis. So everything all the time was cuts, which included our organization having to shrink by about 1/3 as well. What happens when you allow the system to be cut this much is we are actually perpetuating some of the most expensive parts of the system to the detriment of other interventions that are more effective for people, more culturally responsive to people, cheaper. But I hate making the argument based solely on money. But I don't know that most people realize that the average length of stay in an inpatient psychiatric facility that's state operated is more than 3 years. That's separating somebody from their community for literally years. You can't, I've been a patient in an inpatient psychiatric hospital. I lasted 2 months. I cannot imagine being separated from my family on a locked psychiatric unit for longer than that. But when you don't have staff, it means people can't do visits to the community. It means they can't necessarily get out for fresh air, even though they make efforts to do that. But it makes all of those things harder. So it makes the conditions of confinement worse for people. And
more expensive, right? I mean,
and way more expensive, like to the cost of hundreds of thousands of dollars a year to keep somebody in an inpatient, you know, the per diem cost. So that would be one thing that I really think the state should think about is how do we create a system where those beds are available for people when they need them, but only for as long as they need them. And then we get people back to their lives.
Keisha, how have you seen this, you know, these austerity budgets impact the population there?
All right, so like when you were saying, asked about like when the COVID hit, right? COVID came in 2020. We know that, we get it. It impacted a lot of people's lives, everybody's lives. Nobody knew how to deal with it, right? But we in 2023 now. We can't keep blaming everything on COVID. We adapted. We're moving on like any infectious disease that a pandemic that hit, you know, our country. We need to move on from, you know, because of COVID, or we don't have services and we cut budgets for that. Our patients out in the mental health addiction services wards need to be reopened. They don't belong in jail, right? Because jail is a prison. They don't have anything to do with their mental health. That is a medical condition, right? As far as the legislative, they need to not talk the talk if they can't walk the walk. Come see us, come talk to us, come visit DMHAS down there where it looks like a ghost town. When you have all these people hanging in our emergency room departments and crisis center, and they're not being seen properly because they're not being taken care or being managed because of, again, shortage of staffing. Going to bring it back to that, to be able to fulfill the needs of our patients. So in the prison setting, like I'm at, they need to have an HR department that can hire hire people to come in, nurses, doctors, because some people do say that they applied and it'd be like 9 months before they can even get in, so that they can open up these facilities. As you know, they're still shutting down some of the prisons. So we're really going to be impacted. So I think that for the legislation, for the cost and they need to basically, I think Kathy said it, to come talk to the people, come talk to those, the ones that's affected, and to talk to those that's being drafted for 20 hours.
Marisol looks like she wants to chime in here. Can we unmute Marisol?
Legislators, we talk about bottom line. Nobody wants to just put everything down to nickels, pennies, dimes, and dollars. However, what we're doing is we're back ending it. Rather than front loading healthcare practices and programs, which would save the state and everyone long term by providing jobs, providing the adequate support and the adequate services. Instead, we're back ending with these negligent suits and these other litigation costs that we now have to pay due to the fact that, maybe the legislators need to go down to DOC to take a look at what it looks like there, or they need to come down, away from the legislative building and take a look at what it looks like in downtown Hartford, where you see many people, COVID or not, homeless due to mental health, mass incarceration, all these different things. They're here for the world to see. I think choosing to turn a blind eye or choosing to say, these austerity issues that we've done for the last few years don't work anymore. We have money. It is time to put your money where your mouth is. It's no longer sufficient to say Connecticut is this preeminent criminal justice reform pack leader anymore, when we're not even taking care of our own that are in the streets due to mental health, decarceration, all these other things, because they're not providing the services and the money that these programs need, or the staffing issues that, whether they close the prison, all they're doing is just stuffing them somewhere else. Though our numbers are dropping, but let's be realistic, COVID-19 put the carceral state in hiatus while pre-sentencing people, the court system was tied up for what it was. We're now seeing a resurgence of that. We know these numbers are going to go back up. I did a project myself in my last semester that shows we know rates are going to go up again, unfortunately. But what you're going to end up doing is sitting with all this money in our coffers. What good is it going to do us? All these people, we're going to have the people on the street, people with no programming, staffing shortages. Everybody's going to get weighed upon, but there's no resolution. Instead, we're going to end up paying out all this money that could have been put in preventative care instead of, hey, let's just slap a Band-Aid on it because we now have to throw money at them after the fact. I think that's ridiculous.
Thomas wants to weigh in on this.
Yes, and I agree with Kathy's earlier comments, especially about how you don't want to make this all about dollars. These are real people, real lives we're talking about at the end of the day, and I love the passion of everyone on the panel here, as well as the network of mental health advocates we have out in the state of Connecticut. They really help bring to light what people really experience. But when you get right down to it, you have to be able to talk about the dollars, because any bill that's going to ever get through the legislature always winds up at the Office of Fiscal Analysis, and they create this thing called a fiscal note. The good news is we can paint a really compelling story that, if we could spend money on the front end, we can affect the crisis response system, which is hugely expensive on the back end, and have a wonderful, much more positive and therapeutic system for the people who get caught up in it. So I don't think we should be afraid of that discussion at all. I think we should be, not only pounding the table with our compelling stories, but then say, hey, oh, by the way, we can save some money to the state as we're helping people, which I think is a win-win and a message that can't be repeated often enough.
So nobody seems to have any questions in the chat. So I'm just gonna maybe we'll just go around the horn on this last question. We know that inequities of race, class, gender, and disability contribute to the crisis of unmet need. What are some examples of how this plays out on the ground in your experience?
The way we see the kind of impact of what we need to address as systemic racism and white supremacy is when especially we see that reflected in forensic mental health numbers straight up, because you layer the criminal legal system involvement on top of the mental health system involvement. And because we have the system set up the way we do, where it's oriented towards a politically appointed board that has a mission of primary mission of protecting public safety, and then also, balancing that now that they have to, specifically in statute, balancing the needs of the safety and well-being of the person who's been acquitted because they've been found not guilty by reason of insanity. But that's where you actually see disparate numbers. If you look at the rest of the numbers of the DMHAS service system in terms of demographic breakdown, it pretty much matches the demographic breakdown of the state. If you look at those numbers in forensics mental health, the number of Black, especially men, who are in that system is out of whack, because our criminal legal system is out of whack and has a disproportionate impact on Black men. And we see people who, if they had served their time in Department of Corrections, would have been out, would have re-entered our society. But because they're under the jurisdiction of the Psychiatric Security Review Board, they still remain in a locked DMHAS facility. These are folks who have a lot of wisdom, a lot of experience. They always say, if you want to find the solution to a problem, go to the people who are most impacted by that, because they will actually have the solutions, because they know what works and doesn't work. And we're losing that. I think the fact that we are able to do events over Zoom, that people can testify over Zoom, that was the first time there's really been a dedicated effort by organizations to coordinate people inside being able to share their voice. The fact that people inside DOC wrote testimony that people read at the hearing, that people inside of DMHAS testified over Zoom at the hearing, that did change hearts and minds. Not as much as it needs to. There's still more work to be done, but it made a huge difference.
I say this because I live in Hartford, which has the largest incarcerated population. A lot of people get dropped off here, and it affects largely the Black and brown communities. You see it here so often with people that it affects the mental health, people who become homeless after being released either from incarceration or even from halfway house programs, because they come out without the ability to have technological ability to even make the calls to do their initial appointments. Because again, a lot of people sometimes, they're not prepared with discharge planning upon release. Again, staffing doesn't allow for that sometimes. Again, time doesn't allow for that. People are released without the appropriate level of medications for mental health or certain, health, whether it's diabetes or other things. They get released with maybe 2 weeks to 30 days of a supply, but with the way that, again, we can't just put it down to COVID-19 with the surge we have in the inabilities to get into doctor's offices for follow-ups, just for preventative healthcare. Last year when we did Senate Bill 448, the coalition tried to they try to codify basic preventative medicine. And that's not something that's still able to be done. Again, lack of staffing, be it doctors, nurses, we don't have the manpower to be able to do this. So then it puts an additional financial burden on social services and healthcare. Husky, when they come out here, they have to get dental services, mental health services, physical services, all just because they were incarcerated. They come out, they don't have either a referral, or even if they do, sometimes it's so far out because, again, it's, whether it's someone within the network, not within network. All these things are barriers for the Black and Brown community, for everyone, but specifically for the Black and Brown community, because, again, we don't have, those who are just released. I didn't have access to a phone when I first came home. You have to do some maneuvering just to be able to get a telephone if you don't have family, or just being able to get an appointment just to see an OBGYN, or just to get a physical. Now you have to wait for telehealth and all these other things. And with the restrictions that supervision puts on you when you first come home, it's difficult. So that's an additional strain. Again, these are the barriers that everybody faces, but more so the Black and Brown community, because, again, these things, lack of housing, lack of healthcare, lack of resources, we just face big lack. And with that, how is that plausible after having, again, our coffers are full, but the state doesn't want to fund public health? I think that should be a shame on them.
LaToya or Keisha, did you want to chime in here and get a last word in before we wrap up?
I just wanted to say, like, just a few years ago, when I used to discharge our HIV population out into the community, we had created some years ago an avenue to where they can get out and streamline with another case manager to connect them into care. I always felt that should be for every inmate that we have in the facility, because you have some people in there that will never come to medical but have issues and need to see their providers when they're leaving out. I mean, they don't serve them the best food, right? So they end up being pretty underlying diabetics. You take a test, a lot of people become diagnosed in prison. Let me just say that. So recently now there's like not even services for the HIV population to go to, right? They just get out there and try to find the best way they can. They still do have a little case manager, but even those services are far and short. It's the same with our mental health. Unless you got to be severely ill is where they try to get you connected. But those that's just maintaining don't get the help. But when they get that out there on the street, they become that high level because they're not connected into care. So a remedy to that is that the legislation needs to know that we need to streamline, on my end, when they are in prison, a way that they all get connected when they get out, so they'll have an environment to survive in. I want to say, instead of becoming homeless, we live in the richest state. There's no reason why. One inmate told me the other day that he's back in because he said in the halfway house, there's so many drugs in the halfway house. He's like, oh, Keisha, there's so many drugs in this prison, more than is out on the street. So we need to fix that. There's definitely a huge disconnection, but I feel like the baseline was done when it came to certain patients, but we just need to streamline it to all.
LaToya, did you want to weigh in here before we get going on the unmet needs and how it impacts certain populations more than others?
I just wanted to say, like, I really advocate a lot for the women because I invested a lot and heavily involved in the community for the women, that I really just, I gave them my word that I was going to use my voice to advocate for support for them, for more funds for the programming for them. And that's what I'm here to do. So I just feel like I have said what I needed to, and I don't want my ego to show up and start saying things I shouldn't. So I'm going to stop here.
Thank you. All right, Thomas, one last thing.
Yeah, I just wanted to draw people's attention to something that just crossed the wires today. I'm a longtime subscriber to the Hartford Courant, and there was an article in the paper today that was headlined, "The Connecticut House and Senate approve a state police contract to improve recruiting, retention, trainees get a 35% pay increase by 2025. And it just really struck me, because what happens when you can't get the help that you need when you need it? a lot of people, unfortunately, the people we care about end up getting tied up in the criminal justice system. Now that seems like the state is more than willing to fund the cleanup crew. And again, no disrespect meant to the men in blue. They do a wonderful job, and I have a lot of respect for them. But if the state is definitely going to make sure that they get funded, then they should sure as hell make sure that the services that our people need to be healthy should also get funded. And I'll just leave it at that.
Well, thank you guys so much. I want to thank you all for your participation. This was a great panel. Good luck this year. I'm going to turn it back over to Rebecca.
Great. Thank you so much, Christine. Thank you to all our panelists. Just a really moving way to start our event. Before we go to the break, we're just going to hear from one more speaker, Pam Colello. Pam works as a dental hygienist in the Department of Developmental Services, and she's here to talk specifically about a critical service in DDS as an example of a public sector program that we really need to protect and expand. Pam?
All right, thank you. Good time to have me on right before lunch, so that everyone will realize the importance of teeth while they're enjoying whatever they've brought today, and how important these services are, especially for the people that we treat here. So my name is Pam Colello. I've been a hygienist for 38 years, the last 13 years here at Department of Developmental Services in the Norwich Dental Clinic. The dental services that are provided here have evolved over the years. They've changed from the institutional care to community living arrangements. Our staff in Norwich consists of a dentist, a dental assistant, and 2 hygienists, all full-time. And the dentist was formerly, the first dentist I worked with, so just to give you some background, worked at Mansfield Training School, and the dental hygienist that I replaced worked at Seaside Regional Center. And this dental clinic opened in 1980 when those facilities were in the process of closing. The Norwich Dental Clinic, like I said, has 4 full-time staff, and we treat patients, almost 1,000 patients from 119 towns. 73% are from the South region and about 27% from the North region. There are 3 other dental clinics in the state. They aren't the size of ours, and the staffing is only part-time at 2 of them, and they are all in the West region. Southbury, Norwalk has Lower Fairfield, and El Grasso in Stratford. Now, all the individuals that are provided services through DDS can receive dental services at our clinic. We have patients that live in public group homes, private group homes. They live with families. Some live independently in the community. The Norwich Dental Clinic provides critical, very specialized services for the patients. Staff and family members who accompany our patients to their appointments are appreciated for their services that they provide during the dental appointments here. Many patients have limited verbal skills. Many are even nonverbal. And we recognize the knowledge that the staff and the family are able to provide for us. And we work well to provide safe, comprehensive dental care here. We hear time and again from staff and family that they are not treated this way in the community. And for several reasons, the community just don't understand or have the time to treat our patients. The dental rooms in community dental offices aren't conducive to having extra people in the room, or the staff are uncomfortable, having those extra people directly in the room while they're providing care. And this results in little to no dental treatment for our patients, since their advocates are not utilized to provide comfort or even to explain the procedures in a way that our patients would better understand. We adapt to our patients don't adapt to us. Community offices either don't have, like I said, the time, they don't have the specialized education or the desire to work in this manner. The Norwich Dental Clinic is specifically designed to accommodate wheelchairs of any size. We have overhead lifts for patients that cannot stand and pivot to get into our dental chairs. Our dental treatment rooms have sufficient space for patients who have custom contoured wheelchairs. and must remain in their wheelchair for treatment since they can't comfortably or safely sit in our dental chair. The staff have repeatedly told us that there are no such accommodations at community dental offices. Now, our dental clinic was shut down for, not for staffing issues, but management closed us down in March, and we just reopened December 1st. So we were closed down for about 8.5 months. Is that right? And we continued to advocate for these services throughout that time. We encouraged parents, guardians, caregivers, staff, agencies, anybody that we could think of to contact state legislators for support for reopening the clinic. During those 8.5 months, we canceled upwards of 800 patients, and that was almost 1,500 visits because many of these patients had multiple visits. So there were a lot of people that were denied care, in my opinion, during that time. So the stories that we've heard from staff since we've reopened have been heartbreaking. They just didn't find care out in the community, although they did try. They would call us every day and ask where we could, refer them to, and it was limited depending on the abilities of the patients to be able to be seen in those offices. We've been reopened for about 6 weeks, and just this past week, we had a group home staff. They had never been to our clinic because they were hired, during the shutdown, but they had gone to the community offices with their patients. Jen, my fellow hygienist, and I were working in adjoining rooms. So we each had a patient from this group home, and the staff were there helping out. And they were so excited when they saw the treatment that we were able to provide and how comfortable and tolerant the patients were with us. The staff reported that the patients had been seen in the community, but they did not tolerate any treatment. And the community dental staff were able to do a cursory look in the mouth at best, but basically no treatment at all. And here we provide as much treatment, and encourage patients, and they really tolerate us quite well. The past 8 weeks have been very rewarding. I know I said we were open 6 weeks, but I guess it's been 8. Patients are full of joy when they come in, and many have arms outstretched in the waiting rooms. I mean, they're looking for hugs. They're screaming when they see us, and when they tell us how much they've missed us, we can sincerely say that we have missed them more. So the joy is back in the dental clinic right now. Our clinic is a very important example of the public service to our community that really needs to be protected, maintained, and even expanded. We're booking pretty far out. If a patient has to cancel an appointment, we're booking 3-4 months out now. Yeah, about 3 or 4 months out. So all people, whether you have a disability or not, can receive high quality dental care. They should receive the high quality dental care that they deserve. And that's what we strive to provide here at DDS Dental. Thank you, Rebecca, for inviting me onto this panel. I really appreciated having time to speak.
Thank you so much, Pam, for your powerful remarks and also your work providing dental services for folks with developmental disabilities, whether they have insurance or not, all across the state. And like Pam said, it's just a critical example of a public program that exists, to make sure that no one falls through the cracks. So now we are going to go to our break. The break is going to be 50 minutes. And so we will return at 2:00. We're so excited for the rest of our program. Don't go anywhere too long because we'll be hearing remarks from Senator Saud Anwar, the chair of the Public Health Committee, as well as Dr. Emily Wang of the Transitions Clinic Network and the SEICHE Center for Health and Justice at Yale. And then we'll hear another amazing panel before we wrap up with some closing remarks. You won't want to miss it.